Hi, Stephanie Erickson here, author of Plan for Aging Well. Here's the book off in the corner. I am a clinical social worker and I've been working with family caregivers for the better part of my social work career. And in the last 15 years, I've been focusing on working with individuals that have a neurocognitive disease, or probably more widely known as dementia, even though the new term is neurocognitive disease. And today we're going to be talking about COVID and the impact on people who have that diagnosis. And I'm really excited because Dr. Philip McMillan has agreed to sit in with me and have this discussion. Very interesting man. The thing I really like about him is that he focuses on recovery and
Mhm.
rehab, and he has this desire to completely reverse the impact of dementia and the disease in and of itself. And I love that, seeing a physician not looking at a disease model, but looking at a way to recover and rehab from that. So I'm really excited to have you, Philip. Thank you so much for coming on.
Thank you very much. You may see me tapping away, Stephanie. And what I'm doing is I am sharing the live on my LinkedIn connections as well. So I'm just sending this out. If you just give me just 1 second to
Sure.
take advantage of technology and post this out. There we go. That's now shared to my connections, the live link. So thank you
Perfect.
very much for having me.
You're welcome. Thanks so much for being here. So first, let's just talk about um, dementia in general and just the stress and the impact on an individual who has this diagnosis, regardless of COVID. What do you see in terms of the most stressful pieces for the patient, the person who has a diagnosis, and then for the family?
This is a biggie, and quite truthfully, from a clinical point of view, from a clinical point of view, we're concerned about life. We're concerned about saving lives. We're concerned about reducing the risk of serious infection, and very often, quite honestly, we forget about the other stuff. And so we don't even think about it. And so this is why this is so important, because what it does is brings us back to, even though we're doing those other things, we still have to remember the person, and we have to remember the families in the midst of it. But it's so hard, and I can tell you from a clinical perspective, when you're battling with patients who are unwell, and you're getting the calls all the time from the relatives when they want to find out, and you're just thinking, I don't have the time. I don't want to talk about that now. But it is still so important. So you're
And
right.
yeah, and it's so wonderful to hear you from your professional position say this, because I find that some percentage of physicians with whom I work on files are very focused on the clinical aspects, which I understand because that is their role. However, we can't ignore the social impact on the entire family system. Nobody has a disease in and of itself. It's not just the one person and the disease, it's an entire system that's impacted. So I really appreciate that support. For the people that have a neurocognitive disease, a dementia, what's been happening with COVID when that impacts a person? And I'd like to kind of, if we can, talk about it a bit in silos. Like, I want to talk about what it looks like in long-term care residences, what it might look like at home, and what it might look like in hospital settings. So first, let's take into account long-term care residences. When COVID has hit these residences, we know that it's killed a very high percentage of this population. But what's been the impact for specifically for individuals with dementia?
Yeah, so the first thing is that we'll differentiate our location. So you're based in Canada, I'm based in the UK. Now, truthfully, I did watch some of the issues that were happening in relation to Canada and the impact of COVID in long-term care facilities. And truthfully, we had a very mirrored experience in the UK.
And in the States, they did as well,
Yeah,
actually.
yeah.
Yeah.
And so just to put it in context for people, when the first wave hit, the primary target was to try and see if we could keep hospital beds available. All right. because you knew that more patients will come. And if you ran out of hospital beds, that's when mortality really goes sky high. And so the aim was to try and get as many people out of the hospital environment into safe facilities. And for quite a number, that was in long-term care facilities. But here's a problem. A lot of the patients were swabbed or not thought to be COVID positive. But the truth is we didn't know, because sometimes the symptoms are so subtle that you then in effect spread the infection into the care homes. And once it hits that environment, it just goes round and round and round. And that's what happened in the first wave. And it's a connection between the hospital and the care home, and then the fact that it's going around in the community. So even the people who are supporting in the care home are potentially bringing it in. So it's a very complex mix that is very hard to manage. And the truth is that I'm not sure if we've learned as many lessons as we should have from the first wave, because we're still probably making some similar mistakes in the second one.
Oh, we are here for sure. We're in a mess in a lot of these long-term care residences. Again, we're in a complete mess. But I wanted to ask you specifically about someone who has dementia. Is there a different way that COVID impacts that person in a physical way in terms of what the illness might do to that person's functioning?
Yes. So let me give you a basic understanding of something here. When we speak of dementia, the simplest thing for people to understand is that dementia is about the fact that the brain can't use glucose efficiently, okay? As long as you have that principle in place, and because the brain can't use glucose efficiently, it's always functioning at the edge of survival, okay? Anything that tips it over the edge worsens dementia. And it usually presents with what we call delirium. And for people who don't recognize, delirium is the very acute confusion. So meaning that somebody's a little bit confused, and then suddenly the next day they have no idea where they are, they don't know who you are, they're shouting, or sometimes they're just sleeping all the time. That's what we call hypoactive delirium. That is the way oftentimes, and the research suggests, that's the primary way that many patients with dementia present with COVID. They suddenly go confused. And it's essentially just a delirium, an acute confusional state, or a worsening of the confusional state that is specifically related to either medication or, in this case, infection.
So then that would mean, because I mean, we see this with UTIs, right? Urinary tract infections. And a lot of people who work in care residences say, well, you know, my patient who has dementia can't communicate, but when the behavior changes, I know that there's an infection going on, and they look at the behavior. So that to me speaks to even more difficulties that the residences are having, because when these symptoms change, and if the person is more confused or aggressive, or I don't like that term aggressive. I prefer the term protective, meaning they feel like something's wrong and they're doing something to protect themselves.
Yes.
But clinically, people say aggressive. That then creates more staffing needs, right? Because you need to manage these more difficult symptoms. So that's probably contributing as well to why this population is struggling so much, is because their care needs are increasing just based on symptomatology.
Yes, absolutely. And one of the things, as I said, in terms of the research that I was looking at, one of the things that it highlighted is that there was a significant increase in delirium for people who were at risk or had dementia. Okay. But what's more worrying is that the people who had delirium had a much higher, almost 3 times higher rate of dying with COVID than the average person. Now, there's a combination of factors there. Is that the person with delirium is oftentimes more frail. And do people understand what I mean when I say frail?
I believe so.
So just imagine an older person who has a loss of fat here. So they've got temporal atrophy. So the temples are sunken in, the eyes are sunken in. They're very, very slim, and they look as though they've been losing weight. That's a typical good example of what a frail patient looks like. So even though the numbers were higher of people with delirium that died, it was because a lot of them were so frail. And in frailty, they don't have any reserve. They have no fat reserve. They have no muscle reserve. They have no physiological reserve to handle an infection. So it's not surprising. It's almost what we expect from a clinical point of view.
And is that going to be the same thing? Because we're talking about long-term care residences for a person who's in the hospital. Like, is there a comparison between the death rate or the way that COVID is impacting someone with dementia, residence versus hospital versus home? Are there any differentiations in the research?
Well, what you will find is that when they did a comparison between in hospital and the community group, they did find that there was still an increased risk of mortality, even in the community, but it wasn't as high as it was in hospital. And that's probably quite practical. So meaning that if somebody's a little bit unwell, they tend to stay in the community. If somebody is very unwell, they tend to come into hospital needing oxygen. And so therefore, straight away, the patients who are in hospital tend to be sicker. And so because they're sicker, there's a higher risk of mortality.
And for the caregiver impact, I mean, if someone in the community who has dementia and has a caregiver already, a spouse, an adult child, maybe some home care services, maybe not full time, but part of the time, and then they get COVID, obviously there's now a risk of other people within that care circle also contracting COVID. Is there any research or statistics done on what happened in terms of that person then having to be hospitalized because their caregiver came down with it and then could no longer care for them?
That one I don't know for certain in terms of clear research, but I have observed the characteristics. So what you tend to find, the caregiver who usually has an issue, it's usually the couples. So you have a husband and wife, both are older, both are frail. If one of them gets COVID, they're both going to end up in hospital unless there is family around to support the other one in the community. And so you usually see that kind of pattern. And I'll tell you one really practical issue that I don't know what the answer is for this. This is something I've raised on multiple occasions, is that when people get sick, there's this strange pattern that they then get taken into hospital. They're okay. They may need a little bit of social support. They then go back home, and within a week, they're coming back with COVID. And that's really a consistent pattern that you see oftentimes. And it's around something that we have not been very good at dealing with. And the Italians noticed this first when they had the major outbreak in Europe, because they were the first people to get hit after China. And one of the interviewers said something that's very important. The hospital becomes the epicenter of the disease. So it means, therefore, that when people get in contact with the hospital, and they go back in the community, they're oftentimes bouncing back, potentially with contact with COVID. There is no easy way to fix that one.
No, there's not. And it's just like, that's a general thing that we say is the worst place to go when you're sick is the hospital, because you end up coming home with something else. And on top of that, as if you've gone to the hospital, and especially if you're older, you have dementia, then you come home, you will need increased care. So now you're introducing other people into your little bubble as well. And then there goes that community spread. So in terms of like where we go from here, just with dementia in general, I want to move away from COVID for a minute, because you're doing a lot of research about really trying to completely eradicate this disease. Where are we on that front in terms of research?
So part of what I'm doing is that I'm approaching dementia from a different angle. And this is what I've been doing over the past 10 years. And to put it in context, what I've done with dementia is that I've stepped back from it and I said, we've got multiple conditions that cause dementia. Now, people only think of Alzheimer's, but there are a range of diseases that cause dementia, ranging from syphilis, multiple sclerosis, Parkinson's. There are just so many diseases that cause dementia. So my question is very simple. What is the primary pathology that links all of these forms of dementia? When I understand what that is, I can take that knowledge to understand our most common form of dementia, which is Alzheimer's. So right before COVID hit, and this is why I'm talking about COVID. So in February, when COVID hit, I had just reached the point where I think, quite honestly, I've got all the pieces mostly together. But when COVID hit, I thought the technique that I used to research dementia, I decided to apply it to COVID. And this is how, out of that, I developed the autoimmune theory of COVID, which is apparently correct. So I'm way ahead of everybody else with COVID. And it's quite likely I'm way ahead in terms of dementia. So dementia, once you understand the fundamental biochemistry with regards to dementia, it gives us a chance to make a difference. Okay? One of the things that I don't know is when patients get to an advanced stage of dementia, I don't know if even with the best will in the world, I can pull that back. But what I strongly believe, and this is that now I'm going to have to prove this in time, is that even patients with mild symptoms, or more importantly, mild cognitive impairment. Is that a term people know what I'm talking about when I say that?
Well, I certainly know what that is. And just to, well, you can explain it, but mild cognitive impairment can be what a lot of people just say seniors issues, or it's just mild symptoms and it may never progress into dementia. By the way, if you've ever heard that diagnosis for yourself, it doesn't mean you're going to get dementia. Sometimes it doesn't progress, but it's just kind of like, oh, we're seeing something here. Let's monitor it.
Yeah, absolutely right. What it is just a bit of forgetfulness that's worse than what you would expect, and it's progressing faster than what you would think in somebody who is aging normally. So it's mild cognitive impairment. Here is our mistake. We ignore it. That is not to be ignored. And so here's an example I give as to my thought with dementia. Just imagine that somebody had a chest x-ray. And on that chest x-ray, there was a shadow. It was just purely incidental. They didn't have a cough. They weren't short of breath or anything. You then did a scan, and it looked as though it could be cancer. So you then did a bronchoscopy, took a sample of it, and you confirmed, yeah, this does look like cancer. But then you said to the person, you know what? You haven't got any symptoms. So let's just wait until you get some symptoms and then we'll try and do something about it. That makes no sense.
It doesn't. That is such a hard leap for people because even in terms of just your great example, which is a fantastic example is using cancer. When it comes to, dementia or Alzheimer's, a type of, or any of the other types of diseases leading to dementia, people are so afraid of that they don't want to know. They don't want to hear it. They don't want to address it. And I think that's one of the biggest leaps is almost going, okay, before we even get the person into the doctor's office, how do we even get to that person, right? Communicate with them that having a baseline of your brain health is super important to move forward and prevent or eliminate any of these potential illnesses. How do we do that? How do we go backwards?
Well, I think that what we have to do is look at the example with cancer. There was a time where when you said cancer, it was a terminal diagnosis, similar to what happened with HIV in the past. People then, when they heard that diagnosis, were so scared that they would rather not to hear it. Okay? Now, because of the progression with research and therapy, cancer is no longer a frightening word. I mean, it still is a problem, but there's so many things we can do. It's the same with HIV. Here's the problem with dementia. When someone says you've got dementia, Yeah, you've got it. Nothing to do. What do we do? And the answer consistently has been, well, let's just see how it progresses. That's what frightens people. It frightens people that, there's just nothing there, no options. That's what needs to change. That's what I'm trying to change, is that we've got to give people options where there are things that can be done, not only just to prevent it, but I am going for the holy grail, is I am trying to reverse it.
That's amazing. And in the beginning, you talked about, as you were explaining a bit about dementia, you talked about glucose. So is this where you're headed in your research? Is because I've heard before people say, oh, dementia is diabetes type 3. They're making these kind of suggestions that it's connected. Is that where your research is?
No, not quite. So
Okay.
the concept of diabetes, type 3 diabetes and dementia is just purely because people have noticed that there's a problem with glucose. But I'm going to give you an example. I like telling stories, as you can see, Steph. So let's give you an example. When we think of type 1 diabetes, okay? So in type 1 diabetes, just imagine that we didn't know what was going on. And we see these people passing a lot of urine and they're losing weight. And someone says, well, that's the disease. It's a disease of passing a lot of urine. So then somebody checks the urine and realizes, oh, goodness, they've got a lot of glucose in this urine. That must be the disease. No, but then they check again. They've got elevated levels of glucose in their blood. And that's why they've got high levels of glucose in the urine. So they then say that must be the disease. No, it still isn't the disease. Then they find that there are low levels of insulin in the blood. So that must be the disease. No, the disease is in the pancreas, in the beta cells where it produces insulin. So if you cut out the pancreas, that person is going to have diabetes. If you do radiotherapy on the pancreas and kill all the beta cells, that person is going to have diabetes. That's primary pathology. It's the same with dementia. What we are looking at with the brain and glucose is equivalent to the fact that there is there's glucose in the urine. It's not the disease. It's just a manifestation because of what is happening beyond it. That's the bit that that's the bit that I've answered. And so in order to do that, I'm thinking over the past week, I decided, you know what, I need to put some of these thoughts in a way that people understand. So I'm developing an ebook called The Fundamentals of Dementia. And what it's going to do is hopefully get anybody at a baseline understanding about the disease and where research is currently. Then once they've understood that, I can then take somebody into a more detailed understanding into things like, why are mitochondria important? That kind of thing. So you have to go more in the biochemistry. And then when you understand the bits that need to be fixed, that's where we have the opportunity.
This is really exciting. It's really exciting. And I like feeling your energy and your passion for this. And I hope that you're going to be winning the Nobel Prize for your discovery of how you've reversed dementia.
Oh boy, yeah.
That's what I'm hoping for. Let me put my glasses on because a few comments came up and I just want to see. Some people were putting some links for some things. And one person, Jack Cumming, I'm going to just put it up there, said COVID knows no borders and honors no politics. That is for sure.
That's very true.
Before we're just about on time, I wanted to try and cut it off at about 25 minutes because people need to go eat their lunches. Well, here it's lunch. For you, it's
yes.
Where are you at? Are you at an after dinner drink?
I'll have some soup.
Yeah, exactly. Is there anything else that you wanted to share before we finalize our discussion?
Yeah, I think that what I'll do, Steph, is that I'm working on that principle of the fundamentals of dementia. It will be a simple ebook with some pictures, which will be free. And in that, I want anyone a teenager, probably not somebody less than 10, but and anyone to be able to understand where we are today with dementia, with the tests we do it, why we do it, and so on, in a simplistic way. And it will give them an understanding of where it's going to go next. That's the aim that I want. They just need some basics to understand so that they can see where to go for the future with dementia. But it is exciting. We've got solutions.
It's amazing, and make sure you share that with me, and I'll pass it on. And I'm really hoping that there are more monies poured into this area of research. We have and I'm not minimizing any of the other research that's being done in all of the other disease areas. It's all equally important. But I'm hoping, and really it's in the society's best interest, because people are aging and this tends to be a disease that affects older people, right? So
Yeah.
it would benefit if we can get some more money poured into this so we can find some solutions. And there's a financial benefit for governments anyway, because I'm always trying to think of how can it affect someone's pocketbook. Otherwise, they don't
Yeah.
care. Well, it's going to save them money down the road with all the care and support that people need who have the disease. So if they
Yeah.
just want to think about saving money.
I'll tell you one point as we're coming to an end with that.
Sure.
The thing that people are not recognizing is that the age group for people affected with dementia are getting younger and younger.
Yes.
It will soon become everyone's problem. That's why we need to do something about it very, very quickly.
That's scary. That's very scary to hear, actually. And do you think, I mean, I guess we're kind of going back into your research, but the research that you're doing, and when you're going backwards to find where is the disease at, where
Yeah.
is it starting at, is that related then? It doesn't have anything to do with getting older. It has to do with a different kind of process within our body. And that's why younger people are more and more affected. Like, why is that?
Yeah, well, there's one thing that will eventually come out, and this is where the big challenge will be. The example is going to be what happened with, say, unleaded petrol. When we had to take lead out of petrol, there was a huge outcry. The big oil producing companies didn't want to do it, but it was affecting children and making them sick. Without a shadow of a doubt, for a disease to have 50 million across the world and be rising, there's going to be a significant environmental component.
Mm.
When that's clear, we have to all join together to say, okay, this is important and we have to do something about it. That's going to be the big challenge for everybody, because without a shadow of a doubt, an environmental component is a huge part as to why we're seeing these numbers across the world.
I totally agree with you. And it's probably the case with a lot of diseases as well. I just watched this documentary. I think it's called Kiss the Ground, and it was about the soil and how all of these solutions can be in our soil. And when you watch it, I mean, it makes complete sense, because everything's being dumped into our soil, which grows in our food, and then we eat our food and it's making us sick, So I'm sure there's that environmental component. But this is exciting. Make sure you get back to me with that ebook. I'll make sure to share it. And where can people reach you if they want to ask you a direct question or connect with you in some way? How can people reach
Yeah,
you?
so at the moment, what I'm growing is Dementia Crowd Research. That's on Facebook and on LinkedIn. That's where I'm sharing more sophisticated research thoughts, as well as ideas about carers and some of the challenges people have. That's the starting point, and that's what we're growing over the next few months. And that's where we're going to reach out to people to make a difference for dementia.
Awesome. So send me that link, will you? And then I'll make sure to post it. And if anyone is interested, you can get my book, Plan for Aging Well. It's available on Amazon. Thanks so much, Philip, for taking the time to discuss this with me. Let's connect again in a few months if you've got some updates, and do this again.
Absolutely. I love talking about dementia, as you can see.
I can see. Okay, well, great. Thank you again so much.
Thank you.
Okay.
Thanks for having me.